that had a TBI, you would have an uncontrolled first rocker, and this is because your dorsiflexor strength is lacking, and so you would see like maybe a sharper drop into that first plantar flexion during first rocker. During second rocker, you would have decreased dorsiflexion, and this is as your plantar flexors get tight, and also your dorsiflexors are weak and can't contract to move the tibia over your stationary foot. Due to differences in strength, you might have a more quick move into third rocker as your body tries to control the movement using those plantar flexors. And then during swing phase, your foot might not or wouldn't get to neutral or the dorsiflex position, so you could be at risk for toe drag. You'd stay in plantar flexion longer.
So for our patient with TBI, she's having difficulty getting her foot into dorsiflexion, especially for the swing phase, and that's leading to possible safety issues with toe drag. So for gait training, we can tie a TheraBand around her shin, and then it goes around like the forefoot of her foot to help bring her toes into dorsiflexion as she walks. So we would just cue her toes up and then have the band help her assist her toes into further dorsiflexion. Okay, so another option for our patient is to have her do heel walking. So this helps address some of the weakness that she's having in her dorsiflexors. This would help bring her foot further into dorsiflexion, especially during that swing phase, to help clear her lower extremity. Third option for our patient with TBI would be to have her do some stretching of the plantar flexors, and this could be done functionally. So a way to do that is to plant the leg that you desire the stretch on. They can use the wall as support, and then you step the opposite leg forward, keeping that back heel on the ground, and so that stretches the posterior cord of that back leg, and that can help her do that second rocker motion in a functional manner to improve her gait.
With weakness of the quadriceps, you see immediate differences at initial contact. Normally you go into about 15 degrees of knee flexion, but with weak quadriceps you might lack knee flexion because this is more stable to go into knee extension. Your quadriceps are weak, so they wouldn't be able to eccentrically or concentrically control that initial knee flexion. So your knee ends up in an extended or hyperextended stance position, and this brings the ground reaction force anterior to the knee. Your knee would then be hanging on your posterior capsule, which would be the part that was giving a flexion torque. So the swing phase is then about normal if you have quadriceps weakness.
And then hyperextension of my right knee. Okay, so if you have weak quadriceps, one of the ways that you could strengthen them is by having your patient walk in like a crouched position, and this would turn on and activate the quadriceps so that they could get used to using them in a weight-bearing position. So that would just look like this. So you want them to contract their core, their quads, and their glutes. Okay, another treatment idea for quadriceps weakness would be mini squats for the purpose of strengthening and neuromuscular control. So mini squats are a good idea because your knee range of motion is not to the extremes during gait, so you don't really need to strengthen throughout the entire range that is available at your knee. Specifically, it requires 60 degrees of knee flexion, but more specific to the quads, you need strength up to about 20 degrees of flexion for the purpose of that shock absorption in initial contact. So you would just teach your patient to use their quads as they do mini squats. You can use tactile cueing if they're having trouble, or EMG feedback.
For circumduction of the hip, I looked at hip AV adduction. So normally your hip goes from 5 degrees of adduction in stance phase to about 5 degrees of abduction in swing phase. With a circumduction deviation, you can see increased abduction during the swing phase. Adduction during the stance phase is typically normal, and it's not until after the double limb stance that you might see a little bit of an increased sharpness in this part of the graph, as well as an increased overall range of motion for abduction. It's not well controlled by musculature or like muscle activity, and it's typically due to a functionally long swing leg, which is causing this increased abduction.
Okay, hip circumduction of my right leg. So for hip circumduction of my right leg, you can have your patient walk along a surface such as a couch that would give them tactile feedback about the position of their leg and cause them to have to walk with knee flexion and hip flexion. So I'm going to show you. So walking along a couch. Ta-da! Okay, stop. Okay, so one of the reasons why you might have a functional leg length difference would be having weak hip flexors on the ipsilateral leg. So my right leg is the one circumducting. That could be the one that has weak hip flexors. So to treat this, we could have a patient do an exercise to strengthen their hip flexors. So that could just be using a TheraBand and resisting hip flexion against it.